Hello everyone, this presentation will be on enteric fever. Now enteric fever is a common infectious disease which we encounter in India, and in India it is quite common and predominant, hence it's important to have a good understanding of this topic. Now by definition and by name, the name enteric refers to intestine, and fever is a fever which is a rise in the body temperature more than 100.4 degrees Celsius or 38 degrees Fahrenheit. So generally it is because of an acute generalized infection of the intestinal lymphoid tissue as well as or the gallbladder. Now commonly it is caused by either the typhoid or paratyphoid organisms, 90% attributed towards the typhoid organisms and the remaining 10% to the paratyphoid organisms. Now historically it is quite important. The name takes origin from typhus meaning rickettsia like and phytos meaning putrefaction or as a result of food. Historically, we all know the story of Typhoid Mary, who was an asymptomatic carrier but had infected millions of people through her cooking in London. Apart from that, it's important to know that historically it was separately identified by Huxley in 1972 and much earlier by Gaffkey in 1884, and even earlier than that Schlolin in 1839. However, these are more from a historical perspective, but Typhoid Mary is the most famous story in modern times. Now coming to the organism, we know that it is a gram-negative, non-acid fast, non-capsulated, non-sporing bacilli, and it is a very die-hard organism of sorts, which effectively means that the individual becomes a lifelong carrier. If you see the subtypes of the typhoid organism, it has 4 subtypes: Salmonella typhi. Paratyphi again has 3 subtypes, A, B and C respectively. Antigenically, if you see, there are 3 antigens which are of importance: the O antigen, which comprises of the cell wall, the H antigen, which is the heat labile flagellar antigen, and the VI antigen, which stands for virulence, surface virulence, which is heat labile. The O antigen is heat stable and H and VI antigens are heat labile. Now these antigens are what we use for serodiagnosis based on the viral test. Now the spread and the epidemiology of it is quite easy to understand. There is no gender predominance, and the spread of the typhoid or paratyphoid, the enteric fever as such, is because of contaminated food, contaminated milk or water, and predominantly spreads by the fecal-oral route by poor personal hygiene and poor sanitation. If you see, older children and young adults are more commonly seen, and very young age group less than 5 years comprise of just 10% and less than 2 years only less than 2%. So if you see, generally age wise it is somewhat older children and younger adults, often with a history of eating outside or contaminated food. Now if you continue to see this epidemiological aspect of it, annually occurrence, it occurs throughout the year. There is no seasonal variation, but there is generally a spike in the cases between July to August associated with summer and early rains, and it's generally seen in underdeveloped, somewhat poor socioeconomic areas. And if you see, carriers generally 20 to 50 years they do last as carriers, with female tending to last as carrier more, and the incubation period lasting for almost 1 to 2 weeks, but it can be as much as 3 to 60 days also. Short incubation periods, however, are more commonly seen. Now if you do see globally, India is one of those regions which is endemic and hyper-endemic towards typhoid, and compared to Western, more developed countries, it is somewhat higherly seen in our Southeast Asian region. So it's all the more important to understand this topic. If you see the routes of transmission, the patient or the chronic carrier, both of which have stool, vomit as well as the urine, the typhoid bacillus can be seen in any of these 3. Now from here, if you see, there is either an indirect infection or a direct infection. A direct infection can infect even a healthy subject, whereas an indirect infection will affect through the infected food or water. And as an end result, typhoid fever does occur because of the dissemination of the bacilli. So it is important to understand by the routes of transmission, a direct infection or a chronic carrier, or indirectly infecting through food and water. The ultimate result is the enteric fever. This flowchart is important from an examination point of view. If you see the pathogenesis as such, post-ingestion there will be a multiplication intraluminally followed by an increase in the intestinal luminal tissues. From here, the bacteria enters the bloodstream and further disseminates into liver and spleen on one side, and on the other side into infecting the bones, skin and CNS. Further, there is a reinfection of the alimentary tract and is excreted through the stool and multiplies. And from the liver and spleen, there is also release of the endotoxins, which results in toxemia and damaging the other systems, including the central nervous system also. So there can also be a multi-system involvement of typhoid fever. And if you do see other systems which are involved, the musculoskeletal system, skin and central nervous system are predominantly affected more. If you see intestinal lesions because of the invasion of the intestine through the rugae, perforations and ulcers are quite often complications what we do encounter. Ulcers initially in the initial stage and later on when they develop into perforation too. If you consider the effects of typhoid fever upon other organs, it can have its effect on the liver, gallbladder, Peyer's patches, spleen, solid viscera, heart as well as bone and bone marrow too. Now the effect on each of these individually. Upon the heart and major vessels, it can result in vasculitis, it can result in osteomyelitis and bone marrow suppression. Upon the liver, it can present with jaundice, and gallbladder, it can cause cholestasis as well as acalculous cholecystitis as well. Upon spleen, it will result as splenomegaly, and Peyer's patches will be affected because of lymphoid hyperplasia. So other associated gastrointestinal symptoms will also develop. Now clinical features, if you do see, it is of an acute onset in general, and generally typhoid fever is a continuous fever with a morning remission every day. Now, by definition, continuous fever is where the fluctuation is less than 1 degree centigrade and there is no touch of the fever to the baseline. Generally, enteric fevers are of moderate to high grade and persist for 6 to 7 days, but the classic stepladder pattern is often not seen in children. The reason attributed towards this is on-time use of antipyretics, one, and the second thing is due to the innate immunity as such of the child. Now, if you do classify the enteric fever into 4 phases, the first being incubation, second being invasion, third being the status, and fourth being evolution. Generally, in the incubation phase, the first phase, the patient will be asymptomatic and baseline temperature will be maintained. And gradually, in a stepwise manner, there will be an increase during the invasion phase. During the invasion phase, there will be an oscillating fever with dissociated pulse, headache, as well as gastrointestinal disturbances such as diarrhea or vomiting. Now, the next plateau phase or status phase, which is the third phase, is where there is a constant state and persistent diarrhea and splenomegaly may be seen. And de-evolution phase is where the temperature accordingly does come down, but the patient remains a carrier. If you consider day-wise, up to the incubation phase, you consider it as day 0 or the subclinical phase, up to day 7 as invasive phase, 7 to 21 as a status period, and beyond 21 days as the evolution time. Other symptoms associated with enteric fever can include myalgia, anorexia, reduced appetite, vomiting, diarrhea and or constipation. Now this is important because constipation can also be caused as a result of hyperplasia of the Peyer's patches. So we do generally associate enteric fever and typhoid to diarrhea, but the other end of the spectrum, constipation, is also possible. Though a rare differential, it is something we must consider. Apart from that, a toxic look with pain abdomen, headache as well as cough can also be pointers towards enteric fever. But the predominant complaints what we do get are anorexia, diarrhea, a toxic look with pain abdomen and an occasional headache. Now clinically, if we do examine, there will be a tympanitis of the abdomen with a soft splenomegaly if the fever is of more than 1 week duration. Hepatomegaly may or may not be present along with a coated tongue. Now if you see characteristically, pain abdomen, tenderness, hepatomegaly, splenomegaly is the most common presentation what we do get. Rarely chest findings of rhonchi and crepitations may be seen. Now rose spots is pathognomic to typhoid fever, but due to complexion is not seen in Indian children. This is important from an entrance exam point of view. Rose spots is pathognomic for typhoid fever but is not seen in Indian children, and it may also be associated with other complaints like mild to moderate anemia, meningismus, or very rarely manifestations of jaundice due to liver involvement. Now, coming to the complications of typhoid fever, the CNS complications include encephalopathy because of altered sensorium, convulsions because of toxic cases, or even meningitic features. Gastrointestinal complications include hemorrhage, perforations, peritonitis or hepatitis. Respiratory complications are those which are similar to chronic bronchitis in early stages and later stages which mimic pneumonia. Cardiovascular complications include myocarditis, which presents with features of bradycardia and a systolic murmur. Skeletal features, like I mentioned in the initial slides, can be osteomyelitis or rarely aseptic arthritis. Aseptic arthritis is a hyperacute picture, whereas osteomyelitis is a chronic picture which is seen in the bone. Skin changes include alopecia and furuncles plus rose spots, but rose spots are not seen in Indian children. Apart from that, it is associated with a UTI in 20 to 25% of cases as renal manifestation. Now, other atypical manifestations such as otitis media, parotitis, epistaxis and thrombosis may be seen and are quite rare. And it may also be associated with febrile seizures if in the febrile seizure age group. Now, the diagnosis of enteric fever is generally a clinical diagnosis and is seen in fevers of more than 7 days of origin, with or without associated features like toxemia, pain abdomen, altered sensorium, or hepatosplenomegaly of mild, moderate, or severe form. Though clinical, there are diagnostic measures. Now, enteric fever is not one of those conditions where a simple investigation will cover everything in one shot, irrespective of the duration. Enteric fever is sensitive towards the duration of the fever, and according to the duration of the fever, the investigation alters. So, in the first week, the gold standard investigation to be done is bone marrow culture rarely, but quite commonly what is done is blood culture. Now, in the second week is where we do the antigen test, which is viral. The viral test will come sensitive only and only in the second week, and that is a key take-home message which I would like to highlight. Now, we know that the second week starts post a 7th day of fever. So, only after a 7th day you can do a viral test, antigen test. Doing the test on day 4, day 5 or day 6 can give a false positive or a false negative, so it is to be avoided. In the third week, characteristically because of the intestinal invasion, it can be picked up only by a stool culture, and in the fourth week of the fever based on urine culture. Despite being unable to pick up with a strong clinical suspicion of enteric fever, what I would like to highlight extra is in the 5th week, the gold standard test to be done is the bone marrow aspiration. And based on the bone marrow aspiration, the bone marrow culture and sensitivity can pick up the Salmonella typhi, and this is the ultimate gold standard investigation to identify. Now, it could have been done in the first week, but it is best reserved to the 5th week because of the invasive nature of a bone marrow aspiration. Now, coming to the vital test a little bit in detail, the agglutinins do appear in the blood by the end of the first week. Now, initially we did mention while studying the antigenic structure of the organism that there are two, the O-agglutinin and the H-agglutinin. The O-agglutinin rises rapidly 4-fold in 10 to 14 days and persists for months but does disappear within 1 year. The H-agglutinin rises slowly and persists for years together. So, based on this, we can understand that the O-agglutinin is what is important for a recent infection. Now, when a vital test is reported, it is reported in terms of a titer either 1:80, 1:160, 1:320, etc. Now, many people in some labs do give reports in terms of 1:20, 1:40 also. Now, ideally, a 1:1 would be what is normal. In the Western world, 1:20, even 1:40 can be considered as positive, and 1:80 is considered as strongly positive in the West. However, here in India, due to various exposure levels, even 1:80 can be considered as a normal based on the lab standard, and 1:160 and above only is considered as positive for enteric fever. So, by definition, what I am emphasizing is a 1:160 alone to be taken as enteric positive in our Southeast Asian continent like India, and 1:80 can be considered as weakly positive if no other feature is present. However, in the West, by 1:40, 1:80 itself, they do tend to label as enteric fever. One more key point which I would like to highlight is that a rise in the H-agglutinin can also suggest recent immunization or even a past infection. So, a merely rise in the H-agglutinin cannot be considered as enteric positive. Now, as with any antigenic test, there will be a false positive or a false negative. A false positive can be seen if immunized recently with a typhoid vaccine, if repeated subclinical infections are there, a past clinical infection as we discussed, or in patients with cirrhosis and hepatitis. A false negative can be seen in too early blood collection of the sample, or if the patient is already started on antibiotics without a prior culture being taken. This is generally the most common false negative what is seen, and the remaining 5 to 10% do not respond to antibody formation. If we consider other lab findings, there are various degrees of anemia which are present due to other reasons, and eosinopenia, generally the presence of it suggests a slow recovery. Increased ESR is also seen along with other lab evidence of DIC in more severe cases. Other complications can include hyponatremia, hypokalemia, and elevation of liver enzymes, with some amount of protein, white cells, and urine in stools also showing other features such as proteins and white cells in urine and leukocytes and or blood present in the stool also. Now, differentials of enteric fever, initially we should think of an infective diarrhea because diarrhea is the most common complaint with which an enteric fever patient does come. Stool examination will generally rule out the other causes of infective diarrhea, pointing us towards enteric. Now, in the initial day 1 itself, nobody will suspect an enteric fever. So, viral fever will often be considered as the most common cause, but viral fevers are self-limiting and will cut down itself within 7 days. Urinary tract infection, of course, will show features on urine analysis, so accordingly it will show variation. Malaria can be ruled out based on the smear examination. Biliary TB will present occasionally with rare symptoms but can be ruled out based on chest X-ray and MAN2. Appendicitis will show features of a raised cell count with the presence of fever and tachycardia, all three. Bacterial endocarditis can be picked up on blood culture and echo findings will also be there. And accordingly, Kala Azar will show double rise of the temperature but the patient will have a good appetite. So the good appetite is a distinguishing feature between enteric fever and Kala Azar. So in general, these are the differential diagnosis what we do consider for enteric fever. And one by one, based on history and basic simple clinical investigations and clinical examination, and other investigations, we can rule that out. Now, coming to the treatment in general, after investigating the case, tepid sponging is used to subside the temperature if it's a low-grade fever. Paracetamol can be given to reduce the fever as per the weight of the child. It is important to ensure that adequate water and food intake is maintained and to hospitalize the child if child looks toxic, if there are complications, or if the child requires IV fluids or other therapy by IV route. Now, we classify into complicated and uncomplicated typhoid fever. Now, uncomplicated typhoid fever is where it is merely fever turning as enteric positive, requiring the antibiotic, and subsequently is more than sufficient for treatment. And generally, these can be managed as an outpatient. Now, if fully sensitive organism, chloramphenicol or amoxicillin was considered as a first-line choice. However, in practice, nobody is following, and cefixime is considered as a first-line choice for enteric fever. Now, in general, the dosage of cefixime is 8 mg per kg per day. But in enteric, the dosage is always given as 20. If we are faced with the threat of multi-drug resistant organisms and cefixime is not suggestive of working, then you can consider azithromycin or even ceftriaxone as a first-line drug and cefixime as a second line. The dosage of azithromycin to be given in enteric fever is 20 mg per kg per day. And ceftriaxone generally is given as 50 to 75 mg per kg per day, but in enteric we can go up to 100 also. Now, the choice of antibiotic here is somewhat individualized. Cefixime is best kept if going on an outpatient. Not responding to cefixime, generally you can go for azithromycin and ceftriaxone as a first line for inpatient. So, to summarize the choice of antibiotics, as an outpatient, you can go for cefixime plus azithro if not responding. If going on an inpatient, you can go for ceftriaxone and azithro. Now, if you consider complicated typhoid fever or severe cases, the first line drug is always ceftriaxone in them because it does have the added coverage of preventing other comorbid conditions such as meningitis. And the opting for fluoroquinolones as a first line in case of multi-drug resistant here. This is the key difference where we don't go for a fluoroquinolone as a first line choice, and second line choice will go as ceftriaxone or cefotaxime. Now if quinolone resistant, then we go for ceftriaxone as a first line followed by azithromycin as a second line. So like I mentioned, in general, to just tell in a layman or as a very simple way, first line choice you can always go for cefixime if keeping as an outpatient. If requiring IP, go for zone. You can step up to azithro if required, and after giving a partial coverage of zone plus azithro or even ceftriaxone alone, to complete the entire course of 14 days of antibiotics in enteric fever, you can even go for a 1 week regimen of ceftriaxone followed by 1 week of cefixime, but it's a highly individualized regimen and it depends on the improvement of the patient and other conditions also. Now if you do see the dosages of enteric fever, though the slide has mentioned out all the dosages, in quite simple practice what we do follow is cefixime, ceftriaxone and azithromycin, and the duration of therapy is generally 14 days except for azithro, which is given for 7 days. Cefixime, ceftriaxone are divided into 2 doses, whereas azithromycin is kept as a single oral dosage. Now other complications include intestinal hemorrhage, encephalopathy, pneumonia, anemia and perforations. If hemorrhage is present, the bed and foot end to be raised, and avoid giving anything orally. Give repeated blood transfusion and pain management through morphine subcutaneously. Encephalopathy is managed symptomatically by steroids, coverage of dexamethasone as well as anticonvulsants. If pneumonia is present, by the time the culture sensitivity pattern comes, after starting an empirical antibiotic can be stepped up and blood replacement therapy given for anemia. Intestinal perforation requires immediate emergency surgical intervention as well as coverage to ensure that anaerobic organisms are also covered by metronidazole. Now prevention is always better than cure, and if you do see the prevention aspect of it, personal hygiene has a very important role in preventing enteric fever. Safe drinking water and good food habits, avoiding unpasteurized dairy products, and public health measures such as disposal of excreta properly, and ban on the sale of contaminated food, and strict measures such as tracing and treatment of carriers and immunization with the vaccine. It's important to note here that the Swachh Bharat campaign has gone a long way in long-term prevention of enteric fever, and it's something which must be encouraged. Now, carriers are those who continue to shed bacilli in the feces for 3 weeks to 3 months after a complete cure. A temporary carrier will generally shed for 3 months up to a year, and a chronic carrier will shed for much more than a year also. A healthy carrier is one who harbors the infection without suffering from the disease at all, and the bacilli will generally persist in the gallbladder or kidney for them. The treatment is only and only by quinolones or cephalosporin and may even require a surgical gallbladder removal in these patients. Now, a quick word on typhoid vaccines before I conclude this presentation. I won't go in detail into the vaccine because it will be covered as a part of the immunization, but a typhoid conjugate vaccine is currently available as Tybar TCV. So this name is important to remember, and it is given as first dose at 9 to 12 months of age and second dose at 4 weeks intervals. And it is given in conjunction with the MMR vaccine to ensure that follow-up is good according to the IAP schedule. A booster dose is given at 2 years of age, and the booster dose can be given either as a conjugate vaccine or a VI polysaccharide vaccine. It's important to note that those who receive the VI polysaccharide vaccine should get their booster every 3 years. And if conjugate vaccine is given, studies have not yet been conclusive as to whether further boosters are required. But a polysaccharide VI vaccine does require a booster every 3 years. So after a second year of age, 5th year of age, 8th year of age, subsequently it is required. On that note, I thank you all for listening to the presentation. I acknowledge the role of IAP in ensuring these teaching material slides are available online as a part of the teaching module 2015-16. This presentation was intended towards medical students and should not be taken as a replacement for medical advice of a registered practitioner. If you feel that you or your children or your family have signs or symptoms of enteric fever, please do consult a medical practitioner for giving history and physical examination. On that note, thank you for listening, and I hope you tune into the next video also.